So, hello, good morning, good afternoon, good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Prof. Ramkrishna Ishwaran. Prof. Ishwaran is a senior consultant neurosurgeon from the Neuro One Hospital, Trichy, India. He was a former assistant professor in the St. John's Hospital, Bangalore, India, and he is a vastly experienced neurosurgeon who has performed over 24,500 surgeries, and he was honored by the Lifetime Achievement Award from the Tamil Nadu Association of Neurosurgeons in 2019. He is also a noted author who has contributed to around 15 chapters on various topics in brain and spine surgery and various textbooks in neurosurgery. He was the past assistant editor of the prestigious journal Neurology India, and is also an invited faculty to several conferences in the country. We are extremely honored to have him today at our webinars, and today we'll be talking about the puzzle of Syringomyelia. The speaker for the second session of today is our honored guest from China, Professor Shi Qifeng. Prof. Qifeng is an assistant professor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He did his fellowship in the Department of Anatomical and Cellular Pathology, the Chinese University of Hong Kong for Glioma research. He also finished the Global Clinical Scholar Research Training Program from the Harvard Medical School. He is the Vice Director of Molecular Laboratory of the Neurosurgical Institution of the Fudan University, a General Secretary of the Neuro-Oncology Committee of the Shanghai Anti-Cancer Association, a committee member of Society for Neuro-Oncology of China, and a youth committee member of Tumor Society of Shanghai Medical Association. We are extremely honored to have him today at our webinars, and today we'll be talking about intelligent molecular diagnosis and neuronavigation of glioma based on intraoperative ultrasound signals. The chair for the first session of today is our honorable senior faculty from India, Professor Sandeep Chatterjee. Prof. Chatterjee is a professor of neurosurgery and head of Department of Neurosurgery at the Vivekanand Institute of Medical Sciences in Kolkata and at the Park Clinic, Kolkata. He has more than 30 years of professional experience in the field of neurosurgery, and his clinical interest is in pediatric neurosurgery, especially spinal dysraphisms. He has chaired the education committee of the ISPN and conducted courses in various parts of the world, and he is a versatile orator with a wide area of interest. He is a noted author with over 100 publications in various peer-reviewed journals. He is also an invited faculty to various conferences conducted all around the world. We are extremely grateful and honored to have him today to chair the session of Prof. Ishwaran. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shuvin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to request Prof. Ishwaran to start his lecture.
Thank you, Dr. Raja and ACNS for this wonderful opportunity to present the work of mine that has gone on for the last almost 25 years. I work in this town in the southern part of India. It's called Trichy, and we have got several historical landmarks going back to several centuries. And in this, we have added our own new monument, and that is the Neuro One Hospital where I work. Today, I'll be talking about the puzzle of Syringomyelia. Actually, I think I should have called it the puzzles of Syringomyelia, because there is not one puzzle, but several puzzles. Are you able to get my audio clearly?
Yes.
Okay, thank you. So I start with a poem about Syringomyelia. I would read it out first. I would like you to keep guessing throughout my talk as to who the author of this poem could be. Syringomyelia, a pain unseen, a spinal disorder cruel and mean. Numbness, weakness take their toll, but some may never feel it at all. As a surgeon, I must make a choice to operate or listen to an inner voice, wait and watch, or take the chance to beat the disease well in advance. The road ahead is long and tough. Our patients are made of strong stuff. Syringomyelics will stand by your side and help you overcome this bumpy ride. Help you overcome this bumpy ride. With that little poem, a literary beginning to our talk, I would base this talk on my experience of 25 years in Trichy, of having seen 234 patients. It's a very modest experience, and having performed 172 operations for Syringomyelia. And the list of causes are very much like in the literature. Most of them are related to hindbrain problems with the KRE1 malformation, or an arachnoiditis, which is prominent at the cervicomedullary junction. And then we have the rest of the causes. The tumor cases are not spinal tumors. They are mostly posterior fossa tumors, which have an additional syringomyelia, which usually resolves on removing the tumor. So this talk has actually three components. One is I'm going to detail some of my patients who have had unusual clinical presentations. The second is we'll talk about the problem of incidental syringomyelia and about the problem of the beneficial occurrence of spontaneous resolution of syringomyelia. Then I'll also talk about a possibly new pathogenic mechanism which I have observed in some of my patients. So first we start with the unusual clinical presentations. All of us are very familiar with the classical presentation with the dissociated sensory loss in the limbs, with trophic ulcers, wasting of muscles, claw hand deformities, and so on. But like all classical things, this is becoming rare nowadays. The new normal is to have spinal pain, somatic pains, limb pains, ataxia, some degree of muscle weakness or fatigability without obvious sensory loss, sometimes not even sensory loss for temperature, and some hindbrain symptoms. These are the new normal findings because of earlier detection due to excessive use of MRI. So this first patient of mine is a young girl who presented with a right foot drop of 1 month's duration. There was no pain in the leg. She had no sensory loss. Her right ankle reflex was absent. And the nerve conduction studies said there was a right common peroneal motor axonopathy. But then it's very unusual for a young girl to develop a foot drop. That's a more commonly an adult problem with lumbar disc prolapses or with common peroneal nerve pressure palsies, etc. So we thought there must be something wrong. We thought of actually a disease in the lumbar root. But then actually what she turned out to have was a Chiari malformation and a large distant syringomyelia that comes down all the way up to the mid-thoracic spine. So we were not sure whether this was really responsible, but then we read some literature and found out that it is possible for the syringomyelia to present as right foot drop. So we did a foramen magnum decompression. I don't call it posterior fossa decompression because our decompressions are very limited to just the foramen magnum area. We always believe in opening the dura and the arachnoid, unlike some people who just do a bony decompression. Did also reduction of the tonsils and a duraplasty, wide duraplasty. So all this was done for this patient, and this patient went on to resolve her foot drop completely within the first 30 days with just physiotherapy. So which means that we have addressed the actual cause of the disease in this patient. And you can see that in the 6 months scan, there is a restitution of the cisterna magna, and there is total resolution of the syrinx cavity in the spinal cord. So the paper that gave us a confidence was this paper in BMC Pediatrics 2018, and this actually came up after this one, but there are a few other reports which were there before this, which are all detailed in this paper. And in this, they talk about unilateral progressive foot drop as a manifestation of syringomyelia, very unusual but well-recorded manifestation. And this is the first paper that talks about improvement, like what occurred in our patient, the one in child's nervous system. After posterior fossa decompression, there is a recovery in the foot drop. So this is one unusual presentation and a good result. The next patient has an even more interesting history of a very long duration. She's a 45-year-old lady who said that 18 years back, she had a sudden sneezing bout. And then she could not breathe, she could not speak, she could not swallow. She needed oxygen for 4 days and she recovered. She just had a very mild upper limb paresthesia for 7 days after this episode. No other investigations were done then. There were 4 more similar episodes with just the breathing difficulty. And in the last episode that occurred 2 weeks before she consulted me, she had persistent dysphonia and dysphagia, typically what you would expect with a hindbrain problem. She had a left vagal palsy and there were no limb signs. There was no dissociated sensory loss or any of the usual things that you expect with the syringomyelia. And this patient had a Chiari malformation and a syrinx cavity. We did the same procedure on her foramen magnum decompression and all the other intradural work that we normally do. And this patient has had complete resolution of symptoms and no recurrence of symptoms for the last 5 years on follow-up. Unfortunately, I don't have a post-operative MRI to show you on this particular patient, but if I remember right, and if I have to go by my records, she did have a resolution of both the Chiari malformation and the syringomyelia. So this is another unusual presentation, episodic breathing difficulty. But not every patient it behaves so benignly. There was a patient who was reported to have had acute respiratory failure from which he could not be brought out. And there's another patient who had a sudden death in whom the diagnosis was made by autopsy of Chiari malformation. The only past history was of migraine. And in this patient, no other cause for the sudden death could be found. There was no hydrocephalus. There was only a moderate degree of Chiari malformation in this patient. So some patients do have bad outcomes in spite of having a very benign disease like Chiari malformation and Syringomyelia. The other patient presented typically like lumbar discogenic sciatica, and this patient had a restriction, straight leg raising. There were no motor or sensory deficits, but the real red flag was the fact that one plantar response was extensor, and that set us thinking. And we got an MRI done, and it shows a Chiari malformation with a large distended syrinx. And with such a large syrinx, one would not take a chance. One would do a surgery, and this is what was done on this patient. And there has been complete resolution of symptoms and no recurrence of symptoms for the last 8 years. And this is a post-operative scan. And you can see that there is a reduction in the distension. There's reappearance of the subarachnoid space all around the spinal cord. The Chiari malformation has regressed a little bit. And there are some areas where the syrinx is totally collapsed, but it's not fully gone. In spite of that, he has got no symptoms, either of the Syringomyelia or of the previous leg pain. So this is also a known phenomenon. It has been reported way back in 97, attacks of pain in the leg from classic Syringomyelia. They don't have any other symptoms or signs of Syringomyelia. Well, this patient has only episodes of drop attacks, which is of course well known with Chiari malformation. But this patient had to be investigated extensively. There was no cardiac cause. There was no raised intracranial pressure. There are very minimal bilateral cerebellar signs and the extensor plantar response. EEG was normal, ruling out a seizure disorder almost. And CT scan was normal. MRI shows a significant Chiari malformation, Syringomyelia. Same procedure done. And this patient had no further transient episodes of a similar nature. So drop attacks. This is a known phenomenon, of course. This is not very unusual, but just to tell you that it can exist without any other significant neurological symptoms or signs. And this is the patient's post-operative scan. You can see the restoration of the cisterna magna, the reduction in the syrinx cavity, and good CSF space around the spinal cord. This has also been reported as cerebellar fits. There are several names given to the drop attacks. Cerebellar fits is one such name. And sometimes it just presents as syncope. In fact, one of these patients reported in the cardiology journal was undergoing cardiac investigation. He was undergoing cardiac MRI when they incidentally picked up the Syringomyelia in the patient, and then finally he went on to have the surgery. Now, we've seen also other unusual presentations like abducent palsy as a sole manifestation, amaurosis fugax without any papilledema or hydrocephalus, acute quadriparesis as a presenting symptom, acute sensory neural hearing loss. This patient was operated recently and he started gaining back his hearing after the decompression of the posterior fossa. Migraine can be a presentation, and migraine frequency reduces after surgery. And Charcot shoulder is another manifestation which we have seen rarely. And this patient also had a good resolution of both the symptoms due to the Charcot joint and as well as the Syringomyelia on the MRI. Well, so we have listed out 10 different unusual presentations, and it's good to remember these because these are the things in which you would not think normally of Syringomyelia. I now shift gears and move on to the problem of incidental Syringomyelia, and also we'll talk about spontaneous resolution of Syringomyelia. Again, some more examples. A patient who had neck and arm pain for 3 months. He was a carpenter. There was no weakness, sensory loss, reflexes were normal. He had facet line tenderness, typically like a facet joint arthritis, and limitation of rotation of the neck. But there was a syrinx cavity. Now, do we call this a syrinx cavity or idiopathic cavitation? It is said that if the diameter is more than 1 millimeter and if it extends for more than 2 levels, then it is to be called as Syringomyelia, as adult idiopathic Syringomyelia, because there is no abnormality at the CV junction in this patient. So in this patient, the symptomatic disease was treated by a facet joint injection. He had full relief of symptoms. He was back to his job, and the syrinx remains unchanged over time. So this is a Syringomyelia, which was just an incidental detection without a Chiari malformation. You'll see one more example of a slightly different situation. This patient also came with nuchal scapular shoulder pain, treated by traction, recurrent pain, persistent pain for 6 months, no neurological or spinal signs, X-rays normal, MRI shows a small cavity in November 2011. And then he goes on to have more symptoms and he finally develops a large disc after about 6 months. This disc was operated. He underwent a anterior cervical discectomy and fusion. He had only 75% relief of pain, but he's able to do his job, and that is the post-fusion. There's no change in the small cavitation in the spinal cord. So idiopathic syringomyelia of unknown cause and which has no relation to the patient's presentation or his disease. So there have been a lot of papers about adult idiopathic syringomyelia, and most of the papers say that there is no progression in these patients. The syring size remains stable or they actually regress over time when you follow them up. Only 2 patients had undergone surgery in this series of Roy, and they had done a local arachnoidolysis and syringotomy, but no shunt because these are usually smaller cavities, most often in the upper thoracic region. Similarly, another series, 12 cases, no progression in 11 cases. One patient had an MRI progression, but no corresponding clinical progression. The message is that with adult idiopathic syringomyelia, we need not rush in to do anything about the syringomyelia because it behaves in a very benign fashion. We really are not sure why these cavities occur in the spinal cord. Now, what is the situation in children? There are larger reports in children because we expect that children have a longer span to live and they have more time for progression of the disease. There was a study of 39 patients by Joseph, reported in British Journal of Neurosurgery, and some of them were detected during scoliosis workup. There were no neurological symptoms or signs related to this syringomyelia. There was no progression in any of them during follow-up. Some of them were totally incidental, and 11 of them there was no clinical or MRI worsening, and 14 of them had actually presented with some kind of vague backache, and some of them had improved spontaneously, and some of them had improved after a diagnostic lumbar puncture for myelography in those days. And similarly, another larger report of 48 children, almost all of them clinically asymptomatic and stable or improved. So even in children with isolated syringomyelia without a Chiari malformation, there is no need to rush in and do anything about the syringomyelia. There's no need to unnecessarily worry the parents of the children, saying that your child has got a very bad disease that might progress, because they also come armed with information from the internet. And so we need to counsel the parents about children who have these syringomyelic cavities. Now, my next patient presents a different problem. He presents just with what looks like vestibular vertigo, recurrent episodes. He has a Chiari malformation. He has a syringomyelia, but there's not much of distension of the syrinx here. We offered him surgery because we thought that he's, there's still time for progression. And the general understanding at that time was that syringomyelia left alone would progress. But he chose not to have surgery. He had another imaging at 1 year later. And this showed a slight reduction in the cavity size, very slight reduction. The Chiari malformation is still there here. Then about 5 years later, he developed acute right C5 radicular pain, numbness and weakness. Now you find that the syrinx is almost completely disappeared. There's just a little bit of trace of something here, not a real cavity. And this Chiari malformation is still there in this patient. But what causes his symptoms is the large C4-5 disc prolapse that is there here. And he was operated for the disc prolapse. He became totally asymptomatic, and he remains asymptomatic on follow-up. And there is no further recurrence of the syrinx in him. So I have had 21 patients in whom I would say that we have seen incidental syringomyelia. Incidental means there is no clinical symptom corresponding to the syringomyelia, or there are no clinical neurological signs. I have grouped them into three groups actually. One is patients who are investigated basically for a dystrophic condition, 4 of them. And this is one such example, a child who had undergone a meningomyelocele surgery in infancy. He still has a tethered cord because only the external swelling was removed. The tethering was not addressed at the time of the original surgery. And this child has got a hollow cord syrinx. There is no Chiari malformation. So this is one situation where you would see patients who are investigated for dystrophism who turn out to have syringomyelia. And then we have had patients with Chiari 1 malformations associated with syringomyelia, 5 of them, who are totally asymptomatic. This is one such example. You will see one more example later. And this patient has significant Chiari 1 malformation, large descent right up to C1, and there are very distended cavity here, but absolutely no clinical neurological symptoms or signs. And 12 of them fall under the category which we already discussed, and that's called the idiopathic variety, where there's no other antecedent cause that can be detected either clinically or on the MRI. This is one such example of a thoracic cavity. Typically, these are in the upper thoracic region. Now, why did we get the MRI done on these patients? Of course, the dystrophic patients had type 2 split cord malformation. 1, 2 had, these are not those little localized ones that are there just in the chorda, in the conus region. These are long malformations. That's why they merit to be called as incidental syringomyelia. 2 had lumbosacral lipoma. You also already had one patient in the previous example, previous slide. And 1 had only a skin marker for which the child was investigated. Those with Chiari, most of them had come into our attention because they had scanned for a head injury. The CT had shown Chiari malformation that led to an MRI, and then the syrinx was detected. Some had just headache for which they were imaged, and they had the syringomyelia being detected. The idiopathic ones presented either with a lumbar disc or a cervical disc symptom. 2 of them had actually a lumbar schwannoma and a long syrinx in the thoracic region, not explained by the lumbar intradural schwannoma. 2 had undergone cancer screening, and 3 had been scanned for suspected spine injury. So, incident syringomyelia may come to you in various kind of situations. And what happened to them when you follow them up? We had lost 1 or 2 patients for follow-up, but the remaining ones, the dystrophic patients, most of them underwent surgery for the primary condition, basically untethering surgery, including that patient which I showed you, where we did a terminal ventriculostomy, good resolution of syrinx in that patient. This Chiari malformation, 3 of them had no progression. 1 had actually spontaneous regression. You already saw that patient. And 1 had to have a foramen magnum decompression for progression within 1 year. So after all these patients, only 1 patient had progressed and needed to have surgery. Among the idiopathic cases, 1 of them regressed, which you saw. No clinical or MRI progression in the remaining ones, and 2 were lost to follow-up. So generally, nothing much happens if you do not treat the incidental syringomyelia. Spontaneous resolution of syringomyelia is one more phenomenon that has been studied very well, and this report actually summarizes the other 2 reports also. One is by Muthukumar, who's here in the audience today, and in his case there was resolution of the syrinx after the effort of parturition during delivery. I think the straining somehow caused some pressure change, and it improved the spontaneous resolution of the syringomyelia occurred. So these are 2 reports from India about spontaneous resolution. And if you see all these 18 patients, many of them were asymptomatic or had unrelated symptoms. Related symptoms are only in 7, and during follow-up, the symptoms generally either stabilized, improved, or remained unchanged, but only 3 worsened. Syrinx size reduced in majority of patients, sometimes even resolved completely, and remained unchanged in some. Tonsil descent did not change much, but it still remained. So this is the kind of things that happen on follow-up of patients who have spontaneous resolution of syringomyelia. Now, if you have a Chiari and syrinx, the general tendency is to operate early, but then this is not necessary. This has been proven by another paper which followed up 9 patients. Only 1 of them had to have follow-up, had progression on follow-up, and therefore had to have a foramen magnum decompression. Can you make out which patient is going to progress, which patient is not going to progress? They did not find any kind of difference between the patients who progressed and the patients who did not progress, either in the clinical signs or in the MRI. So these authors question the need for immediate prophylactic surgery if the patient is totally asymptomatic, in spite of the fact that the patient has got a Chiari and a large syrinx. So unless changes occur in the neurological or MRI findings, they suggest that surgery is not necessary. So based on this experience of 21 cases and by reading the literature, I have come to formulate an algorithm of management of incidental syringomyelia. By incidental, I mean the patient should have no symptoms or signs of syringomyelia, and then there should be no enhancement in any part of the cavity, because that would indicate a tumor, and that's a totally different ball game altogether. So when you detect such a problem, they may either have a cervicomedullary junction pathology like a Chiari malformation, or they may have a dystrophism or idiopathic. We'll discuss these groups separately. These may be either children or adults. In children, the fear of progression is greater, and therefore we do frequent serial annual MRI for at least 5 years. And if it remains, the general tendency would be to offer foramen magnum decompression for these patients straight away. But then I think that may not be necessary, because the literature tells us and our experience tells us that the progression is very little in asymptomatic syringomyelia. So there is no harm at all in waiting for some time and checking whether the patient has a clinical or a MRI progression. So if there's no progression, then we just have a clinical follow-up. If it doesn't progress for 5 years, it generally doesn't progress thereafter. If there's a clinical progression, of course, we would do surgery for such patients, foramen magnum decompression. In adults, one MRI at 1 year should be sufficient because the chance of progression is much less in adults. And therefore, if this remains stable, then we don't do anything for such patients. In dysraphism, of course, the surgery is not decided by the Syringomyelia, but by the tethered cord that is there. And that, if that is going to progress, I mean, that's of course a separate matter of discussion, when to operate on the tethered cord, which patient to operate on, which patients would progress, etc. But generally, the tendency would be to do the surgery and then keep the child on follow-up. And if there is no progression or regression of the Syringomyelia, we just continue to follow up, don't do any more MRIs. If there is a clinical progression, we would do a syringotomy in such patients. If there is a local arachnoiditis, we would also do an arachnoidolysis. And the idiopathic cases, we simply wait and watch. No progression, we do MR at increasing intervals. If there's a clinical progression, then the only treatment that is available for them is to do a syringopleural shunt. So this is the rough kind of algorithm which I've decided on based on my little experience with incidental Syringomyelia and on reading the literature. I go to the last part of my talk, and that is proposing a new pathogenic mechanism. I do it with trepidation because this is very tentative as yet. All of us know that there are several theories of Syringomyelia, many discredited, some still in vogue, like the Wertheimer theory of Gardner, Williams-Pershel dissociation theory, Oldfield theory, which currently holds sway. And of course, we also have Goel's proposition that it's a volume change. And these are all the various theories. And you can read a summary of these theories in this new article, which is very succinctly summarized and given evidence for the Oldfield theory from the cine phase contrast MRI. But when you have many theories, it is obvious that it is like the blind men looking at the elephant. Each one says one thing, which is apparent to them from their perspective, from their experience with their patients. So now I will show you something else that confounds the picture rather than clears it. This is one of my patients who is undergoing surgery for a KRE1 malformation with a large syringe, symptomatic. And you can see what's happening. This is a 26-year-old lady. This is this side, to your left is the cranial end, this is the caudal end. So these are the tonsils, this is the spinal cord, and you can see this is the posterior inferior cerebellar artery. You can see that this is a very stiff loop of the artery, the caudal loop of the posterior inferior cerebellar artery, which is sitting right on the obex. It's bound by arachnoid adhesions. I try to move that away and see what happens when I leave the forceps that's holding it. It goes and falls back into that position. And it keeps happening repeatedly. Isn't it very reminiscent of what you see with microvascular decompression, where you take off a superior cerebral artery loop, move it away, it comes and falls back on the trigeminal root entry zone. Exactly in the same manner. It completely covers the lower end of the fourth ventricle and the obex. And you can see how it keeps falling back until you do a good arachnoid dissection, just like what you would do for a microvascular decompression for a cranial neuropathy. This is the left side artery. Left is towards me. I'm standing on the left side of the patient. Patient is prone position. For the interest of time, I would just speed up this video a little. And you can see it keeps falling back innumerable times. Even though I have dissected the arachnoid adequately, it keeps recalcitrantly coming back into the same position of compression. And finally, we wrap it up with a piece of Surgicel, just like what we do. Sometimes we have had to even use Teflon or sometimes a clip to hold the artery in position away from the hindbrain, from the obex, and from the lower end of the fourth ventricle. This is causing pulsations. Please remember that it's not, and there is no reason why this patient should have such a large artery. In fact, the posterior inferior cerebral artery in this patient looked even larger than the vertebral artery itself from which it arises. And that is the peculiar thing here. They are not in the age in which you expect very thick atherosclerotic vessels, unlike what you see with microvascular decompressions. They are not those stiff loops that occur with aging as Janetta had proposed. Now, finally, it stays in place, and then we do the closure. So we propose that there is a vascular pulsation or compression on the obex, which causes this problem. And this is the patient's preoperative imaging, and that's the postoperative imaging. You can see the good resolution. You can ask me whether the resolution is because of the microvascular decompression that I did. I'm not sure. I've done a lot of other things. I've done the foramen magnum decompression. I've done the arachnoidolysis. I've shrunk the tonsils. I have created a lot of space in the cervicomedullary junction. All of them can result in clinical improvement. In addition, I've also done this this microvascular decompression of the obex. Now, the segment that we are interested in is in the tonsillomedullary segment that is there over here, the caudal loop of the tonsillomedullary segment, which comes very close to the, and if you see in this anatomical picture, you can see how close it comes to the tip of the fourth ventricle and the obex. And this is not in one case. We have made this observation in several patients. This is another patient in whom a similar sort of phenomenon is seen. Again, the left artery, keep pushing it away, it keeps falling back into position. You can see this artery. Both arteries are close to midline, but this is slightly away. And this is the one that is very close to the, and that's the floor of the, I just stopped the video there to see, for you to see the floor of the fourth ventricle, the obex. You leave it, goes back to position. So finally you have to reposition it and move it away. In fact, if you shrink the tonsil well enough, and don't disturb the arachnoid attachments of the artery to the tonsil, it would stay away from this region and stop producing those pulsations over there. Another example of the similar thing, many such cases where you see a good vascular cross compression, right? Are you all able to see the video well?
Yes.
Okay, thank you. And we complete the procedure by doing the duroplasty and the usual works. Again, these are the pre and post-operative images for comparison. You can see the excellent resolution of the syringomyelia, and there's also good clinical resolution in these patients. Once we started finding this, we started looking for it in the preoperative MRI, and with the good quality MRI that's available to us now, we can actually image these. You can see the artery over here, right at the entrance to the obex here. And that is the same patient whom you saw the previous image, a very huge artery over here. This is actually forming a big loop here. This loop is going like this. So again, a microarachnoid dissection, just like what you would do with the microvascular decompression for trigeminal neuralgia or hemifacial spasms. And this is a preoperative image. But it's not necessary to have, with microvascular decompression, we know that images may show you a loop, but there may not be actually any trigeminal neuralgia. And similarly, here you can see a loop in a patient who has no symptoms whatsoever. This patient was imaged for a cervical disc prolapse suspect, and this patient also has got a loop over here. So it's not always that the presence of a loop will cause this kind of symptom. Now we are able to see it also on contrast MRI. And this is again an asymptomatic patient who has a large loop, but you see that this is not really causing compression. It's not like in the axial image, you don't see really any compression on the hindbrain structures. One patient with syringomyelia also had a similar sort of loop, also operated, and the symptoms improved. Of course, it's not a uniform finding. We find it in about let's say, about 20% of our patients. And majority of the patients will not have a big loop. This is the kind of artery. You can see the size difference between this artery and the ones which were pathological, which we moved away. This is a normal pica size. This is a patient who had syringomyelia, but there was no loop in this patient. So it's not always found. So of the 124 cases I've operated, in 10 who had some bony anomaly, we did only a bony decompression. And for some reason, we did not have to open the dura in those patients. But majority of them, we do open the dura. In 17, we found arachnoiditis. One of them had actually a pica loop. 96 patients had Chiari malformation, and 15 had loops, that makes it for about 16%, and 11 had a left pica loop, 15 had clinical improvement, 9 had MRI after 6 to 12 months showing good reduction in the syrinx, but I don't attribute all of it to just the decompression. but those vessels look pathological. So now there are several questions that this observation raises. One is this a pathological vessel? I would think definitely yes, because of the very size, because of the fact that you keep moving it, it keeps falling back into position, just like similar vessels that you are going to encounter with trigeminal neuralgia or hemifacial spasms. So I think this is a pathological vessel. It's very looped, very out of shape, very much larger in size, and it's forming a kind of a compression in that region or a pulsation over that region. Now, does vascular cross compression play any role in causation of syringomyelia and Chiari malformation? I don't know, but I think there may be a role. Can pica compression at obex level fit in with the existing theories of syringomyelia? Yes, probably, because it may act as a ball valve according to Williams' theory, or it may increase the systolic pulse pressures in that location and contribute to the pulse waves in the CSF. Could pica compression explain non-Chiari syringomyelia? We had one patient who had a CV junction arachnoiditis who also had a similar sort of loop. Is the microvascular decompression of obex responsible for the clinical radiological improvement? We have come a far cry from the days when the obex was being blocked. Now we are actually decompressing the obex. And this is one question which I cannot answer because we have done a lot of other things, as I already explained, which could give rise to resolution of the syrinx. Should we start looking for pica loop in pre-op MRI and at surgery? I think definitely yes, because then we'll build up a large experience as a world body of neurosurgeons, and we will be able to have something definite at the end of a few years of observation. It is observation that leads to experiments and inference. Now, is there any literature evidence? I did the search on PubMed this morning at 10:34 a.m., 3/8/24, and syringomyelia, posterior inferior cerebral artery, obex. These were the search words that I used, and it returned no results. That means there is no such literature that is available right now. But obliquely, there is some evidence. There was once a paper in, actually I could read only the English abstract of this. I could not read the paper because it's in Portuguese. And this is about what they call as up-down Chiari malformations. Patients who are operated in the sitting position where they observe the descent of the tonsil. And they have shown these kind of pictures showing these large abnormal loops of vessels. And they have made a remark in their paper about left large pica in 2, right large posterior inferior cerebral artery in 1, asymmetric pica in 2, and looping pica in 3. But they have not implicated this in the pathogenesis. And then there's another 2 papers from 2 different corners of the world, one from China and one from the USA, which talk about what are the intradural pathologies and pathophysiology of Chiari malformation in children and adults with and without syringomyelia. Both papers talk about the intradural pathology, and they have noticed that in the Iowa City group, Dr. Arnold Menezes' paper, and this is 43% of patients had an eye abnormal, and they have said that it's pica or branches obstructing the foramen magendi. I think foramen magendi is too large to be obstructed just by a vessel. It's probably causing some kind of a pulsatile compression in the upper, the medullocervical junction, and that is what is probably responsible. So I think this should be, it's more like what they saw was very similar to my cases, and that is the compression of the obex. And this was 22%, very close to our figure of 16% from the Beijing study. And then there is a more recent paper in the neurosurgical focus, which talks about intradural findings in Chiari malformation. Novel findings not previously reported included posterior inferior communicating artery branches compressing the neural elements at the cervicomedullary junction in as high as 26.7%, more than a quarter of your patients. And that is a very interesting finding for me. And that bolsters my theory that these vessels are causing some kind of contribution to the problem of syringomyelia in these patients. I would like to end by making a parallel with trigeminal neuralgia. Dandy had observed these abnormal vessels at the trigeminal root entry zone during posterior fossa root sections in 1934, but he did not attempt to move them away, and he did not think that they were really causative. And it had to wait for Gardner and Janetta in the 60s to start the MVD operation for trigeminal neuralgia. I have made this observation. I have also moved these vessels, and now I'm waiting for the judgment of the world neurosurgical community on this matter. With that, I end my talk. And I don't know if you've guessed who the author of the poem in the first slide was. Did any of you guess? You can unmute yourselves and you can tell me if you have guessed the author. Well, there seem to be no responses. And this is just to demonstrate the power of AI. That poem was written by ChatGPT. Thank you all for your patient listening, and thank you for the opportunity, ACNS and Dr. Raja.
Thank you. We have Prof. Sandeep Chatterjee who has joined.
I'm sorry, Sandeep, I missed you in the beginning.
Hi, I'm sorry. We've had a terrible storm here with lightning and thunder, and all our internets had disappeared because we're having very heavy rain and lightning and thunder here. So I'm sorry it took me some time to get some alternative channels re-established. My apologies.
Okay.
Thank you very much. I hope you have heard larger part of his talk. You can give your comments.
Yes, I heard most of the talk. I was quite intrigued, Yeswaran, by your vessels, these abnormal vessels. And it reminded me, I actually had the good fortune to have as my consultant colleague in Birmingham a man, none other than Bernard Williams himself. And Bernard used to always say that anything, just about anything, can obstruct the obex. He would say it could be a tumor, it could be abnormal dura, it could be bone, it could be anything can obstruct the obex and cause this phenomenon. And he was very dogmatic about it. And as you know, he used to completely unblock the obex and then go through a whole lot of procedures like lifting up the tonsils and burning them, etc., etc. So your talk reminded me, though I have to say he did not specifically say anything about blood vessels, but it reminded me of how he used to say this. And in fact, he said, why don't we do a study where we look at what is obstructing the obex? Unfortunately, the day he said this to me, 5 days later, he was dead. So we never got a chance to do this study. But I'm quite intrigued. I want to ask you a couple of questions.
Please.
Why do you think pediatric syringes are different from adults?
Well, I don't think I have an exact answer, but what has happened is in studies that have been done over a period of time, there is a little greater chance of progression for children. And that is the reason why we tend to observe them if they're asymptomatic with more closer clinical follow-up and more frequent MRI. The progression usually occurs in the early years. And in fact, if you see patients who are coming to you, if you take their histories carefully, their symptoms would have started somewhere during their adolescence, especially patients who come late with wasted hands and all that. Their progression would have occurred over about 10 years. So in children, these things happen. But if you find an adult who's at 60, for the first time you find that he's got a Chiari malformation and a Syringomyelia, nothing has happened to him. He's obviously had it all his life. Nothing has happened to him. So very likely that nothing more is going to happen to him even if you continue to follow him. So I think it is just a factor of age and the amount of time that they have for progression of symptoms. I also think the children are far more physically active than most adults. It doesn't apply to all, but speaking generally. And it is the rises in pressure that occur during the daily activities of, jumping, bending and, playing, etc., which are all done more frequently in the juveniles and younger people rather than older people. And these mechanistic factors, I think, may play a role. This is just my guess. I'm not backed by any data, but I think this is what is likely.
Two more quick questions. Number one, do you think that in children, increase in size of the syringe correlates better with symptoms than in adults?
You'll search me for that answer. I don't know. But one thing is, at least the literature reports say that there is no correlation between the size of the syringe and size of the symptoms and the amount of symptoms that the patient has. Small syringes can cause symptoms. and big syringes may be absolutely asymptomatic. So there is no direct correlation between the two. But what happens during follow-up? Let us say a patient has got a 1 millimeter syringe, it becomes 2 millimeters, then it becomes 3 millimeters, 4 millimeters dia. Will that cause a clinical progression? Even this has been disputed by follow-up studies, but this is something that raises concern. As a clinician, you would be worried about a syringe that is increasing in size on follow-up, because this you think may be a forerunner of the child actually developing symptoms. So I think it is something to be decided on follow-up and not just on the first MRI that you do on the patient.
Yeah, I mean, the Ann Arbor study would suggest that. The problem with children is that there is parental pressure. Once you see
That's true.
size, they keep coming back and saying, my God, that was so many centimeters. It's now so many centimeters, doc. Why don't you do something about it?
Actually, more than the length of the syringe, it is the diameter of the syringe, the amount of subarachnoid space that is available on either side of the cord in the sagittal image, which probably decide the necessity for surgery. If it looks kind of distended kind of syringe, I would be, I would be inclined towards operating on the child, even if the child were not so symptomatic. Whereas, if you are
an asymptomatic child because the parents want you to operate on them.
we do that all the time.
Because typical pediatric neurosurgical question you will appreciate.
I know, I understand that. We do it all the time, but then is there science behind it? I don't think so.
And finally, I don't know, I may have missed this bit. What makes you decide whether you will open the dura or just do a bony decompression?
I go generally by the amount of bony abnormalities that are seen in the preoperative MRI and CT. If there is a significant bony abnormality, like for example, there's already a very big basilar invagination, there is a interning of the foramen magnum, there is a occipitalization of the atlas and such things, I would generally do only a decompression without opening the dura. But of late, I've been opening the dura in almost all my cases. This is what I used to do in the past. It's a long experience over 25 years. Initially, I thought those with just bony anomalies and with a Chiari malformation syringe would probably just benefit from a bony decompression. I know, we are also influenced by Atul Goyal's work on not doing any decompression at all, just fixing the atlantaxial joint. That is another thing for another day. It's a whole matter of discussion for another day. But nowadays, after having found so many patients with significant intradural pathology that obstructs CSF flow, I would tend to open the dura. There are two other instances where I would not like to open the dura. One is in a patient who's already had a previous surgery. In that case, repairing the dura becomes very difficult. You invite the problems of CSF leak in such a patient in spite of a good dural graft. And so in such patients, I would, if the bony decompression done by the first surgeon was inadequate, I would simply complete the bone decompression and wait in such a patient. Also on very young children, sometimes when we have to operate for some other pathology, then we may stop just with a bony decompression. Otherwise, most of the time we tend to open the dura.
I have to tell you that, like you, I have spent 25 years agonizing over which ones to open the dura and which ones not to open the dura. And I've always felt that our decisions as neurosurgeons is somewhat empirical.
Very true. Very true.
Until I was pointed out by one of my friends from France about a technique which now we do routinely use. We do a bony decompression. Then we use intraoperative ultrasound to see if there is CSF flowing across the foramen magnum. And if the intraoperative ultrasound shows very good flow of CSF, I don't open the dura. If there is any doubt in the ultrasound, and now you get very good intraoperative ultrasounds, then if I have any doubt, I open the dura. And I found possibly this is a slight attempt to put science into the decision.
I would certainly be encouraged to try that. Thank you for the suggestion.
Dr. Raja, all yours.
Well, thank you very much, Prof, for joining us in spite of the storm and rain. Thank you very much. And we'd like to open this for discussion. May I please invite Prof. Muthukumar, who is with us today. Prof. Muthukumar is vastly experienced in dealing with these pathologies, also have published several articles on Chiari. Prof. Muthukumar, your comments and questions, if any.
That was a very interesting and very informative lecture, Dr. Ishwaran. I really enjoyed every bit of it, and you have meticulously documented all your cases. And the literature review is very concise. And the thing is, over past 25 plus years, like I think we belong to the same batch. So I've also agonized, as Sandeep said, that what I've realized is this Chiari and or syringe is practically a riddle wrapped in a mystery inside an enigma. So whether we'll get an answer, what is the reason for Chiari and or syringe during our lifetime, we do not know. But I am of the firm belief that there is probably not one single etiology for all the cases of Chiari malformation or all the cases of Syringomyelia. There are probably multiple etiologies, the end product of which might be either Chiari or syringe. So we have to identify the etiology and treat the etiology wherever is identifiable. That is point number one. The second point is one of the most practical problems, which challenging problems, which you highlighted and which Sandeep also highlighted, is how to deal with incidental Syringomyelia, especially in the pediatric age group. I think this is true in adult age group also. In the pediatric age group, of late, for the past 15 years or so, with frequently people to get MRI done for vague symptoms, we do consider come across incidentally discovered syringes. And the thing is, there is a publication, there are a group of publication in late 90s by Thomas Milharan, and he has classified Syringomyelia into communicating, non-communicating Syringomyelia. And one of his publication, he has also showed that the central canal is a potential space. It does not contain CSF. And central canal undergoes degeneration and gets obliterated with the passage of time. If you take autopsy of a 10-year-old and a 60-year-old, 60% of 10-year-olds will have a potential central canal, whereas in 60-year-old is likely to be less. So some of the so-called thin syringes which you are seeing are probably not syringes per se. They are just a persistent central canal. That is something which is, I have followed a doctor's child for the past almost 12 years now. She's perfectly normal. And I made a diagnosis of a persistent central canal. I just saw her 6 months ago again. She's perfectly doing well. So something we should not just, it's just the persistence of a normal structure. That is something I don't have any answer. There is no clear way of knowing whether this is a persistent central canal or a pathologically dilated central canal. There's no way of saying that, but this is something which we have to keep in the back of our mind.
Thank you very much, Prof. Muthukumar. If there are any further questions, we can open up. Dr. Liu, would you like to ask something? Michael?
Thanks, Prof. Thanks, Prof, for a very nice presentation. I have three short questions, Professor. The first one, you told us that some responded to surgery, some may not need surgery. Is there any attempt to differentiate now? Is it through Syringomyelia or just purely a hydromyelia, which have nothing to do with the CSF dynamic problem? In those cases, because some of the report even reported as Syringohydromyelia, where they actually cannot differentiate between each and other. My second question, Professor, is there any CSF dynamic study, cranius Weicker junction, to look of a different possibility of obstruction in those cases that you have treated? My last question, Professor, they're getting more evidence now to reduce the removal of normal structure in neuroanatomical location. And because of that, now even for adult and pediatric, we now commonly practicing foramen magnum reconstruction rather than decompression. Do you have any experience regarding foramen magnum reconstruction in either adult or pediatric? Thank you, Professor.
Very nice questions, but I don't have the answers to those questions. I find it very difficult to distinguish between Syringomyelia and Syringohydromyelia, except in those patients who have got very patent hydrocephalus. If the patient has got a hydrocephalus, I can assume that it is a syringomyelia. In all other patients, it is not in the central part of the cord. It is usually eccentric, and I would think that those problems which we generally encounter, those what is called as the non-communicating type of syringomyelia, which is the large bulk of the problem, that turns out to be something that is a separate entity and has got nothing to do with the central canal at all. So this is my answer to your first question. The second question is about CSF dynamic studies. No, I don't have any experience with those studies, but there is a lot of papers that have been written about this. Are they clinically useful? That is the question that we need to ask. And I don't think in the literature there is an answer for this question. These are all experimental studies that are being done. A lot of reports are there about people doing phase contrast MRI, showing the CSF flow. But is it going to decide whether you operate or not? Is it going to decide whether the patient will improve or not? This is something on which there's only, I think, to my knowledge, a few papers which say that if there is a good differential of pressure and if the pressure differential changes after your surgery, then the patient is likely to improve. So they do an immediate postoperative MRI, show that there is a change in the pressure differential as compared to pre-op, and they have said that those patients are likely to show improvement. But this is only a few case reports are there of this. I don't have any personal experience with phase contrast MRI. The next question is about the decompression. Do I get it that you're telling me that after you have done the decompression, you're going to do the reconstruction of the foramen magnum? I'm sorry, I have not done that kind of thing. I don't know anything about that, about reconstruction of foramen magnum. But why would you reconstruct something which is not really essential? I mean, I don't understand the logic of that, because you're trying to relieve the compression.
Yeah, I think in most study, there's many evidence to show that beside the foramen magnum was small, a majority of cases do have a small posterior fossa. And by elevating the foramen magnum to higher level, we hope the bone will reconstruction into a bigger volume, and that allow us to do a bigger foramen magnum opening, and also allow us to have a larger posterior fossa in the future, and to avoid the risk of posterior fossa.
Basically, the idea is not to just to reconstruct the foramen magnum, but to expand the posterior fossa. That's a very noble aim. I mean, that's acceptable, very acceptable.
Yeah, thank you, Professor.
Thank you.
Well, thank you. I think, okay, you can ask, Michael, please.
Okay. Thank you, Prof. It was a nice presentation. So my question is, do you always do tonsillectomy for KRU1 malformation, or do you have a preference to do tonsillectomy for some of them, or what's your practice in KRU1 malformation?
Okay, that's a very nice question. Actually, we don't do much of tonsillectomy. What we do is we just shrink the tonsils away so that it moves away from the foramen magnum area and it shrinks back into the cranial cavity. This you can do by coagulation of the pia just over without actually getting into the tonsil. But sometimes you find that the tonsil extends all the way up to C2. Those are the cases which require not just foramen magnum decompression, you also need to do the C1 lamina removal, and then you also need to remove a part of C2 to be able to get that. In such patients, sometimes I may be encouraged to do a tonsillectomy. But when you do that, you've got to be very careful about the posterior inferior cerebellar artery, because any kind of damage to that causes a lot of cerebellar symptoms in the patient in the postoperative period. And sometimes it even causes lower cranial nerve symptoms. So I would be encouraged to do only a tonsilloplasty. And I have also sometimes done what is called as tonsillopexy. I just put a stitch of the pia to the dura overline so that it gets lifted out of the way and it is out of harm's way. So this is also something that I do. I call it as tonsillopexy, just fixing the tonsil. Tonsillectomies I try to avoid if at all I can.
Thank you.
Thank you.
Thank you very much, Prof. I'll just wind this up with my last question. As you said earlier in your one of the answers that you would not like to operate a recurrent Chiari, and only if there is an inadequate decompression. So what is in your opinion, or is there anything in literature which says an adequate decompression? Is there a standard of adequate decompression? And the second question is, what is an adequate time of follow-up that is reasonable to evaluate the resolution of syrinx? But as we know from the literature that there is no correlation between the syringe and the clinical symptoms widely. So is there a point at all in following up for the resolution of syringe?
Okay, very nice questions. I don't think any standard exists for the degree of decompression. I would like to see a good CSF volume behind the tonsils and the medullocervical junction. That means basically you're recreating a cisterna magna in these patients. If that is not done, if there is some bonic impingement into that area, I would think that the decompression has not been adequate in such patients. So that is my answer to your first question. I don't think anybody has laid down a standard as to how much you've got to remove. In fact, there are some people who say that you should not enlarge the hole. I mean, it's just like trying to treat an inguinal hernia by enlarging the hole through which the hernia comes out. So if it is a tonsillar hernia, you make the hole bigger, it will come out all the more. So, I mean, this is also a kind of statement that has been made in some of the textbooks and journals. So I don't think a standard exists for this, and each patient is an individual case. Like Dr. Muthukumar said, every case is puzzling in its own way. The second question is, what is the adequate time frame to wait? I would look upon my patients when I follow them up. I do monthly examinations for the first 6 months when they come for follow-up. If I find that their symptoms are improving, if their clinical signs are improving, signs do improve less than the symptoms. Symptoms improve far more. And I would wait for 6 months just to study the result more from a scientific point of view, rather than for the view of benefiting the patient. At 6 months, I would think that any surgery of this kind, you would need to wait for longer period. It's not like removing a meningioma and doing the scan the next day. You have to wait for at least 6 months in my practice for seeing whether the patient's symptoms resolve, whether the syringe has become smaller. Now, if the patient's symptoms persist and the syringe also looks very large, then we need to do something about it. We need to look at whether we've done adequate decompression, whether there has been a secondary arachnoiditis, whether there has been a shutting off of the pathways once again, whether there is any point in going back into the cervicomedullary junction of that patient. If the patient's symptoms are getting better and the image is not getting better, I would simply not worry about it, because we are basing everything on the degree of symptoms of the patient and the signs that you observe in the patient.
Right. Thank you very much. There is a question in the chat box, says, what is your recommendation on minimally invasive subpile tonsillectomy or MIST without craniotomy?
No, I don't know. I have not done that. I have seen it in the reports. I think we need to wait for a longer time to see what are the results of that kind of a procedure.
Okay, well, thank you very much for this wonderful presentation. I would like to request Prof. Sandeep to say his concluding remarks for this session.
Well, I think at the end of the day, we've realized that syringe is an enigma.
It's puzzling.
I think the most important comment was made by Muthukumar, in that syringe is a manifestation of a lot of different things. So you have to treat those lot of different things if you have to treat the syringe. And I think we still really don't have an answer to everything, as these lectures and question and answers clearly demonstrates.
Thank you very much, Prof. I would like to mention to all our speakers and chairs that this is also broadcasted on WeChat, YouTube and Zoom, and we have an update by Prof. Shubin. We have around 380 people who have logged in through all different channels. We are extremely grateful to Prof. Shubin for that. Now we'll move on to the second session. So I'll hand it over to our second speaker, Prof. Shi Chifeng, for his lecture.
Thanks for the invitation from Professor Raja, and it's so nice to back again to the ACNS educational webinar and see a lot of friends. Also, I see Professor Liu is also online, and I really enjoyed the first lectures. I also have several questions, but the time is limited. I can communicate with the first lectures maybe online later. So I will catch up with the time. So I will start my lecture today. So everyone, that's good evening in Beijing time. I'm Dr. Shi from Huashan Hospital, Department of Neurosurgery, Shanghai. And today I will share one of my research work with all of you. That is collaborating with my collaborating computing scientists. And in the last page of first lecture's point, he talked about the AI and talked about the ChatGPT. So this research work is also about the AI, and the topic is the intelligent molecular diagnosis and surgical navigation of gliomas based on the intraoperative ultrasound signals. So I have nothing to disclose. So firstly, I want to introduce the history of my department. So our department carried out the first brain tumor resection in the mainland China. It's about 1950s. So the sample of this tumor is still in the museum of our hospitals. So that's why I'm going to talk about the brain tumors today. So actually for the gliomas, as a neurosurgeon, we all know that the surgical resection is the first step and maybe one of the most important steps to prolong the patient's prognosis. And the extent of resection has a strong correlation with patient's prognosis. But in this paper, it's published in the 2023 from the Reno. Right now, we emphasize more on the tumor residual volume calculation than the extent of resection. Because when we resected the glioma, and after the surgery, we do the MRI scan for the patient, we can see the deformation of the tumor cavity. It is hard to calculate the extent of the resection. So to calculate the residual tumor volume is a better way to predict the prognosis of patients. So in the past, the range criteria tell us how we can define the extent of the resections. So when we resect 100 contrast-enhanced parts of the tumor, or we resect more than 60% non-contrast enhanced tumor and have less than 5 cubic centimeter non-enhanced contrast enhanced tumors, that which we call the supramaxillary contrast enhanced resection. And after that, we will have the classification of the maximal contrast enhanced resection, submaximal contrast enhanced resection, and the biopsies. And we can see the supramaximal contrast enhanced resection will have a good impact on patient prognosis, both on the PFS and OS. But in these papers, that Reno has done a little bit modification on its criteria. The Reno categories for extent of resection in glioblastoma can be classified into 4 categories. The first, also we call the supramaximal contrast enhanced resection. Right now, it means that 0 cubic centimeter contrast enhanced or less than 5 cubic centimeter contrast non-contrast enhanced tumor left. That means supramaximal resections. And after that, the 0 cubic centimeter contrast enhanced and the 5 cubic centimeter non-contrast enhanced has served as a criteria to classify the maximal contrast enhanced resection, which can be classified into class 2A and class 2B. If the residual tumor of the contrast enhanced part is larger than 5 cubic centimeters, that we call the supramaximal contrast enhanced resections. So we can see that it is easier to calculate the tumor residual volume than to calculate the extent of resection. And the tumor residual volume also indicates also can be served as a very good indicator to patient's prognosis. But only calculate the tumor volume is not enough. Why? Because we know that the molecular biomarkers also serve a very strong significance to predict patient prognosis. So how to combine the molecular biomarkers and the extent of tumor resection? And that's a major question. And that also will change the situation of how neurosurgery performs glioma surgeries. So from the literatures that we can see different type of molecular subgroups of gliomas requires different tumor resect extent. For example, that for IDH Y-type glioblastoma, it means just resect the contrast enhancer part is enough. Supramaximal resection will not prolong patient survivals. But for 1p19q codelated and IDH mutant oligodendrogliomas, that means what kind of, you resect a lot or less, that does not mean that you can impact the patient's prognosis. So that's why we have entered into the molecular pathology era in the surgery of glioma resections. But it's we also met some challenges, because actually we can test the molecular biomarkers after the surgical resection because we have the tumor samples. But it is very hard to predict biomarkers before surgeries. So we need to develop several methods or several technologies to make this realize that it can help our neurosurgeon to define the plan to resect the gliomas. So right now we have several methods that we can potentially rapid diagnose the molecular biomarkers intraoperatively, because we have the MRI, because we have the fluorescent navigations, but all these are not so convenient and the cost effectiveness. Ultrasound is a very good technical tools for a neurosurgeon to be used in the surgeries, because it is real time and it is cost effectiveness and it is safe. But there are also a lot of challenges for neurosurgeons, because the study curve for intraoperative ultrasound is long, and we are not so familiar with the images what we saw on the ultrasound. So at present, I think not a lot of neurosurgeons is used to use the operative ultrasound in the glioma resections. So here I want to just introduce technologies that we call the intellectual diagnosis and the neuronavigation by using the intraoperative ultrasound which was collaborated with my computing scientists. So that's what the research, what we are going to do. The first step that we focus on IDH1 mutations in the gliomas, because IDH1 mutation is the most common and most important molecular biomarkers in glioma diagnosis and personalized treatment. So we include 16 cases from Boston hospitals, which is 24 IDH mutants and 36 IDH Y types. So we include all these 16 persons who underwent intraoperative ultrasound scans. So firstly, what we have done is that we used contrast enhanced ultrasound hemodynamics to predict IDH1 mutation or not. Why we do this? Because as we know that the blood perfusion of different tumor tissues, they can vary a lot. For example, the tumor samples, they have very good blood perfusion, and the blood perfusion is more than the neighboring brain tissues. So that's why we choose the contrast enhanced ultrasound hemodynamics as a biomarker to differentiate the tumor is IDH1 mutant or not. So here we use a transfer learning mechanism. That is one of the most classic machine learning methods that we use, because we don't have too many ultrasound images of gliomas, but we have a lot of pictures in our hospital that is about the liver and the breast contrast enhanced ultrasound images. That's first we set up a models by studying the images from liver cancer and breast cancers. Then we establish a temporal convolutional network. That is the model we are going to test in the gliomas to differentiate whether the tumor is IDH1 mutant or not. So that is the workflow for our temporal convolutional network. That is the job done by the computing scientists. So I don't want to talk about more. So here I just want to describe the mechanism of our methods. So for a simple gliomas, we can see there are a lot of components, which is in the green part, that is the necrotic area for glioblastoma. It's a common pathological changes. And along it is the tumor pericamal. And this is the most important part of a glioma where we do the resections. And after that is the brain tissues. And the artery can be penetrated into tumor and the brain tissues. Yes. So here we have we focus on the perfusion emphasize what we call the PE. So every brain tissues or tumor tissues, they have a different PE numbers. And the differences between PE numbers, that is the evidence we are going to use to differentiate whether the IDH1 is mutant or not. So we call this as the PE differences. So here we compare three types of PE differences. One, we compare the necrotic area and with the tumor pericamal. The second, we compared the necrotic area with the brain tissues. And the third, we just compared necrotic and the brain tissues, and we calculate the numbers that these two PE numbers, so that what we call the differences. So we use these two biomarkers to validate which one of them is much more better and play much more better roles in predict IDH mutations. And we found that the PE differences has a very better performance in predict an IDH mutation or not. So that's just two cases I want to present. So here is IDH mutants astrocytomas, and we can see the PE differences is negative 0.89, so very small PE differences. And this is a YDH wild-type glioblastomas, and we can see the PE differences is the 16.99. So we can see if the PE differences is larger, that means this kind of tumor tends to be IDH wild-type, vice versa, and the small PE differences means it's IDH mutant glioma. So after that, we are going to use the intraoperative ultrasound signals to predict IDH1, 1p19q, and the TERT, because as we know, these three biomarkers play very important in the WHO 2021 guidelines for the adult diffuse gliomas. So here we introduce what we call the ultrasound radio frequency signals. That is a novel signals than the ultrasound images. We can see the real images on ultrasound. That is the conventional ultrasound signals. But inside the images, there are a lot of signals that we cannot visualize, what we call the radio frequency signals. And the radio frequency signals contain a lot of information about the tumors, not only the structure, but also some texture and the functional connection inside the tumors. So here, from 2020, in my medical group, I'm going to establish a ultrasound glioma bank. So about 2 or 3 years, we include 116 cases, which we also have the intraoperative ultrasound radio frequency signals intraoperatively. And finally, 16 cases were enrolled in these studies. And I also validate this method in two prospective cohorts, which contain 16 patients and 20 patients collectively. So here is the workflow for me intraoperatively to get the ultrasound, the radio frequency signals. So we can see from the left pictures, when we do the craniotomies, before we open the durals, we use the ultrasound transducer to get the, locate the transducer in the largest tumor segment and to collect RF signals by neurosurgeons. So on the right side, that is the ultrasound pictures that we see, and we can collect it a lot of radio frequency signals inside one pictures that we have a lot of radio frequency signals patches. After that, we got these data. We will do the pre-processing, and we have 3 modules in this deep learning models. One is the long short time feature extraction, and the second is dual domain map convolution. And this kind of modules can use to do a rapid molecular diagnosis intraoperatively. And the third is what we call modules, is what we call intra and intermap attention, that can visualize the molecular biomarkers we detected inside the tumors. I will talk about later, and can be served as a very good neural navigator in the glioma resections. Combine these 2 modules that we establish models, what we call the STEAM. The STEAM can help us do the very rapid diagnosis about the glioma's molecular biomarker status, that is YDH1, 1p-NETQ, and TERT promoters. And for each case, the diagnosis time is less than 3 seconds. So it's a very quick and convenient method. So this is also the workflow for the STEAM models we applied. I don't want to talk about more about this as well. So we're in the 16-7 cases we started, and we separated the cases into 5 categories. One is the IDH mutant only, the other is IDH mutant, TERT mutant. The third is triple positive, and the fourth is triple negative, and the fifth is the TERT mutation only. So all the cases can fit into WHO CNS 5 adult diffuse glioma diagnosis criteria. So the diagnostic concordance reached 96%. It's a very high numbers. That means that our rapid diagnosis scheme is very good, and the sensitivities and the specificities. And then we also compare our STEAM models that with 2 classical models, the machine learning models we are used in the radiomics studies that we call the MAPS radiomics and the ResNet 18. So when we compare our models with the other 2 models, we can see we have very good performance over these 2 classic models. And the ACC of IDH and TERT and 1p-NETQ are all better than these 2 classic models. So for this page, we are not going to only make diagnosis of these 3 biomarkers, and we do another innovative modification of our STEAM models, that from the right side of this page, we can see we use a very small patch, and we extract the weight of biomarkers, positive or negative, within one patch. that we can see the more the red is, and that means it is have a less correlation with the biomarkers. And the more yellow, the more green the color is, and it have a strong correlations with the molecular biomarkers. And that is the basis for the molecular navigation glioma resection I will talk about later. So we also calculate and do a review of the existing methods that do the rapid intraoperative molecular diagnosis of gliomas. We can see there is a lot. There are a lot of methods. It can be described as the ACNS, GCSMS, MRIS, Raman spectroscopies, and quick quantitative PCR. But compared with all these methods, our methods have the less time consuming and the most cost effectiveness, and the accuracy is no superior, no inferior to all these methods above. That means that our STEAM intraoperative ultrasound quick diagnosis system plays a good performance in the intraoperative quick molecular diagnosis in gliomas. So after that, we are going to apply this type of technology into the glioma intraoperative neuronavigations. So let's talk about the ultrasound navigation for gliomas. As I said, that neurosurgeons may not so familiar with the ultrasound, and that is easy to understand. I just want to reiterate that ultrasound for the glioma navigation, we need a long starting curve because we can. It's hard to understand what we saw in the operations. It is not so easy like CT scan or like MR pictures. That's more easy for the neurosurgeons. But we do see in these reviews, there are a lot of neurosurgeons, they do this kind of work and publish the papers. And the conclusion can be see that intraoperative ultrasound is good to help neurosurgeons to resect gliomas. And this is what we see regularly in the intraoperative glioma resection. The left picture, that is the transducer of what we used. Right now, the transducer is getting smaller because for some tumor resection, we don't have so big the bone windows. And the right side is in the picture A, that is the glioma we see in the operative. And after tumor resection, we see the post-operative ultrasound images. Even so, it is hard for us to understand what kind of the structure nearby. And in order to improve such insufficient, there are a lot of papers published to use the MR images fused with the intraoperative ultrasound. I also doing kind of this work in my glioma surgeries, but it is not so easy because as we know that the brain shift is still a big problem for the MR pictures, and we cannot do so good pictures match or pictures fusing with the intraoperative ultrasound and the MR pre-operative MR pictures. So it is also not so easy. But for in these papers, we can find on the intraoperative ultrasound the tumors that is has a very good concordance with the tumor residue we saw in the MR pictures. So in order to conquer these challenges and help our neurosurgeon to use intraoperative sound much more easier during the glioma resections, we are going to establish ultrasound-based AI surgery guidances. So what is the AI surgery guidances? And let's go back to this page. as we saw that on the right side, we can see on the intraoperative ultrasound images, we can visualize the molecular biomarkers on the ultrasound pictures. And all these pictures, all these colors, that means it must be inside the tumor cells, because outside tumor cells, there will no tumor-related molecular biomarkers exist. So that's the basic logic. So when we establish these AI models that we can see on the right side, we can visualize the tumors, and you can see the red part of the tumor can be visualized on the ultrasound images, and the blue and the red and the yellow part, that means is the brain tissues and the edemas and the tumor perichymals and the boundary of the tumor between tumor and the normal brain tissues. So if we have this AI based ultrasound navigators, that means during the operations, we just to erase the red part and the yellow part on the pictures, what we saw on the ultrasound pictures. That means that we are doing very good tumor resections. When we totally resect tumors, theoretically, we can see no colors on the ultrasound images. So that's what we are going to do right now. Here actually, we just perform 5 glioma surgery patients by using our AI-based intraoperative ultrasound guidance systems. It's very quick, and we just after we open the bone scab, we just used a transducer to scan the tumors, and the techniques will receive the data as we scanned just alongside me, and they will do the calculation within about 3 minutes. Then they can get back the data, the processing data to me, and to guide the neurosurgeon to resect tumor and to make sure whether they have the gross total resection of the gliomas. But finally, I want to say that the AI is a very good tool to help the neurosurgeon, not only neurosurgeon, but for all the doctors to facilitate their medical practices. But right now, we should make sure that this AI method also need to process the clinical trial procedures, which we have the positive result. That means this AI method can work. So, and conclusions, I just want to reiterate that the intraoperative ultrasound is a very good tool, not only for the image, just for we can use the image that we get to do the rapid molecular diagnosis for the gliomas, and then we can also establish a molecular biomarker-based AI ultrasound guidance to help us to resect glioma. It's much more easier, especially for young neurosurgeons, because they don't have so many experience in differentiate what the tumor part is or what the normal brain tissue is. If we have these systems, and if we can prove it is workable in the future, it will help the young neurosurgeons do better works. But finally, I would just want to reiterate is that we need further large-scale clinical trials to make sure that our method and this kind of systems is really workable. So that's all for my lectures today, and I hope you enjoy my lectures. Thanks all.
Thank you very much, Prof. Chi Feng, for this wonderful, innovative lecture. It's open for discussions. If Prof. Ramakrishnan, would you like to ask something?
I found it very fascinating, the use of AI in intraoperative, marking the limits of the tumor. I just have 2 questions to Professor. One is, I find that ultrasound is difficult to use in oligodendrogliomas because of the extensive calcification. How do you solve this problem? Does it come in your way is AI able to overcome it? Oligodendrogliomas, calcification, interference with ultrasound.
Yes. And thanks for the professor's questions. It's a very good questions. We don't have a lot of oligodendrogliomas, as we know that the proportion of the oligodendrogliomas accounts for maybe only 10 or 15 percentages. But as I said in my lectures that we are not only used ultrasound images, we just extract what we call the radio frequency signals from the images. So the radio frequency signals, it will not be infected by the certifications. It is just to calculate the inside features of the tumors. Then when we done the molecular diagnosis, we can put back the features to fuse with the intraoperative ultrasound pictures. So, maybe in the future, we have more cases that I can have a very good response to your questions. Thank you.
Thank you. And my second question is, there's a lot of information about AI being used on the pre-operative MRI to find out the same characteristics, the tissue characteristics, the molecular characteristics. Do you have any correlation with that kind of AI diagnosis on pre-operative images? Will it correlate with what you find at ultrasound?
Yes, that's a very good question. Because actually, the first step, we are going to study the AI images the AI method, if it can be used to do the pre-operative molecular diagnosis. We use the MR pictures. So this is the first step. But we found if we use the MR pictures to predict the molecular biomarkers, whether it's a mutant or not, we don't have too many methods to validate our finding is really true or not, because we are not going to do the biopsy or to take the samples so very exactly the same position that we saw on the MR pictures. But for the ultrasound technologies, it's enable us to get the samples maybe on the ultrasound images. We say that this kind of tumor is, this part of tumor is IDH mutant. Then we can take it out and do the quick pathologist to validate whether it is right or not. So we really do this, and our findings on the ultrasound diagnosis is has a very good concordance with the quick frozen pathologist tests. Yeah, thank you.
Thank
Can
you.
I have one more question?
Yes, of course, Prof.
You said you trained your AI based on the tissues from breast and liver cancer. And are they are very molecularly different from gliomas? How does that, I mean, how do you correlate that with what happens in gliomas?
That's a very good question. Because for the in the regular AI studies, we just establish one model for one diseases, because we believe there is no correlationship between different kinds of tumors. But right now we are entering into the era of the big AI model eras. That means we establish a very big models, and this model has learned a lot of things from other kind of materials, not only for the medical stuff, but also for some, just like the pictures, just like the drawing, just like the photographs, and they have a very good, strong learning of capacities. So when we use this model to analyze the intraoperative ultrasound radio frequency signals, we just do a very small modifications, and we can use not so many cases, and then we can have a very good models and with very good performance to predict the molecular biomarkers. And I think this kind of work will do. I'm sorry, I'm not the computing scientist. I'm just want to introduce some advantage technologies to facilitate our surgery and diagnosis accuracies.
Very nice work.
Thank you.
Thank you very much. If there are no further questions, we can call
I
it
hope
a day.
I hope it's not so late because it's almost 10:30 in the Beijing time. I think it's time for a lot of patients to sleep.
Okay. Yes, I think so. So we'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kaito. I would like to thank both the speakers of today, Prof. Ramkrishna Ishwaran and Prof. C. Chifeng, for the wonderful time and support for the ACNS webinar. A special thanks to our chair, Prof. Sandeep Chatterjee, who chaired the first session, and we hope to see you for our future sessions as well. A special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel, and also special thanks to my co-host Dr. Liubun Singh for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.